I'm going to be talking to you about the CT, or the evolution of CT, or the revolution of CT, but in fact, in regards to the performance and the technology and sort of safety from the patient's point of view. So my disclosures are as follows. I'm going to present absolutely nothing new to you at all. In fact, it's going to be all pretty old news. Everything I'm going to tell you today is absolutely plagiarized. All images that you're going to see, pretty much, will be scavenged from the internet. And personally, I've not done a jot of work on any of this technology, any of these components, so in that regard, I'm totally neutral. But I do consider myself a double expert. And a double expert, in my definition, is as follows. Okay. So let's get on. So let's start with the history of CT. Well, it goes all the way back, actually, to obviously 1895 with Conrad Röntgen discovering these new kind of rays. And this was in November. And a few months later, in 1896 in January, he presented a paper at a scientific meeting in Germany, and it was called On a New Kind of Rays. And of course, you've all seen this picture. It's the famous picture of his wife's hand, the radiograph. And this is the official stamped, sealed version. And what's interesting at this point is, he discovered the X-rays. I mean, a lot of people were working with cathode ray tubes, and it was just going to be a matter of time before someone realized that these things were penetrating. But in January of 1896, this was first presented, and by the end of 1896, there was more than 1,000 papers and books that were written on that subject. To this day, it remains the most widely and quickly accepted technology ever in the history of science and research. Nothing has been, not even the iPhone has been accepted as quickly as X-rays were worldwide, and because people realized the usefulness. So 5 years later, in 1901, Röntgen got the very, very first Nobel Prize in physics. But we still carried on. There was a lot of people that were working not in radiology and not even dealing with X-rays, but absolutely vital to what we do now today. So Karl Mayer from Krakow actually created, using X-rays, stratigraphic images. And they weren't computed tomography, obviously, but he is considered the inventor of tomography and X-ray tomography. Johann Radon, who's an Austrian mathematician, not even involved with X-rays, created a series of, he published solutions to these linear integrals that were used ultimately and still are in CT, and were used also in describing how stars are sort of positioned, just from looking at plane images or two-dimensional images. This was further continued by Stefan Kratzmarz in 1937, and he's considered, again, his work on solution of linear equations and line integrals became the basis of algebraic reconstruction techniques in early scanners. So a lot of work was done before we even understood or thought about CT. 1940, Gabriel Frank from Budapest was actually working in the hospital, and he created a mechanical device for doing, not only acquiring tomographic images, but also projecting them. And so he was using this mechanical back projection system, and I show you the diagrams from his patent. You can find all of this on the internet, because that's where I found it, so it's nothing new, as I said. But it's non-computed axial tomography. And then in the 60s, we found a wealth of people now looking at computed tomography. Now, you have to appreciate in the 60s, and most of you probably weren't even, just toddlers then. I think one of the reasons I was asked to talk about the advancement of CT is because I was actually a graduate physicist when, Röntgen, or not Röntgen, Hounsfield. Okay, maybe I'm not that old. When Hounsfield, introduced the CT scanner in 1971, well, I was doing my master's in physics already, so, I was there and just waiting to get involved in something like this. But there was a number of people around the world. There was Oldendorf at UCLA. He actually created a working CT scanner, but it just wasn't very practical because he had the patient sort of move and rotate at the same time, and he tried to present this to people, and they said, nah, it's not going to work. It just wasn't clinically viable. There was a group in Kiev, people after my own heart, some smart Ukrainian people that actually built a working device as well in the 60s. But they published it in Russian, and they never progressed the work, and it sort of just died there. Brownell and Chesler in Mass General, they actually did produce computed tomography images, but they never used X-rays. They used gamma rays and positron emission tomography systems. Alan Cormack at Tufts University, he was the one that, he was a mathematician, and he published a solution to these line integrals, which are still used to some extent in modern CT scanning. And Cormack did share the Nobel Prize with Hounsfield for basically the introduction of modern CT scanners. And then, of course, Godfrey Hounsfield. Now, Godfrey Hounsfield was an engineer working for EMI Labs. And EMI, of course, European music industries were very wealthy. They had lots of money from the Beatles, as you all know, I'm sure. He was funded very, very well. And because he was funded very, very well, he didn't have to publish because he didn't have to provide or try and get any grants. So his work was largely done in secret. And so when he introduced the CT scanner, it kind of caught everyone by surprise, or when EMI did. So the background of Hounsfield is in 1967, he goes to the top neurological hospital in London, or in England at the time, and it was the National Neurological Hospital in London, and he talked to the chief of neuroradiology about his machine, and the chief of neuroradiology basically said, no, you know what, we already have techniques that can do this. We do pneumoencephalography, plain tomography, and angiography, so really there's no need for a new device. Like, we're okay with brain imaging, thank you very much. And apparently this guy then phoned the Minister of Health or something who had put him on, who had put Hounsfield onto this guy and said, look, don't waste my time sending these crackpot inventors. This isn't going to go anywhere. Now, Hounsfield was not going to be deterred, but first of all, I just want to talk to you about pneumoencephalography. You guys probably, unless you're, my age, you don't understand what that is. And that was basically a diagnostic imaging approach to a 3-day hangover, because in order to image parts of the brain, they would inject air into this spinal cavities, this cerebrospinal fluid, and then they would put people on a chair like this, and then spin them around and turn them upside down and shake them around to get the air to be diffused into the ventricles in the brain. And then the patient was hospitalized for 3 days with absolutely the worst hangover you could ever imagine. So this was state of the art at that time. So Hounsfield in '67, after being rejected by the London Neurological Institute, then went to the Atkinson Morley Hospital, which was sort of like the second most important neurological hospital in the UK. And Jamie Ambrose, who was the chief of neuroradiology, did recognize the potential. And so they agreed to put this scanner in, and they realized from the beginning that this was going to be a production device that was going to hopefully, make money and sell. So the entire staff of the hospital were sworn to secrecy. So this was started in '67, and it was 4 years later, in 1971, that the world's first ever CT scan was acquired at the Atkinson Morley Hospital. The data tape was taken after the acquisition. This was a single slice scanner. It was a translate-rotate system, one beam, one detector. It took 5 minutes to do one slice, 300 seconds. And the data tape was taken, whisked across London in a cab. 2.5 hours of processing and analyzing the tape, the images came back. And this is an example of their images. This was a famous photograph where they had actually mounted the original images on one of their boards at Atkinson Morley. So apparently the story is that when the images came back and were shown, the assembled neuroradiologists, neurologists, and the neurosurgeons realized that something of truly spectacular clinical utility had emerged. This was the turning point for medicine as we knew it at that time. This was a huge, huge difference. So 2 years later, in 1973, Hounsfield was granted a patent for the computer axial tomography device. This is some of his original drawings for that patent. Same year, the first clinical patient scan in the US was done at the Mayo Clinic in Rochester, Minnesota. A year later, 1974, EMI was already working again in secret on a prototype body scanner because they realized there was more to image than just a head. 1974, it turns out, I found, interesting enough, was the year that EMI licensed Toshiba to start making scanners in Japan. So that's where sort of Toshiba got into the role as well. Also in 1974, there was a commercial whole body scanner made by Robert Ledley from Georgetown University. He's considered the father of the body scanner. And it was sold. It was actually devices, they sold hundreds of them, in fact. It was the automatic computerized transverse axial system, or the ACTA scanner, and they used 30 photomultiplier tubes instead of the single detector. So now we were getting into slightly more sort of multi-detector systems. So by 1975, we had body scanners, we had head scanners. Not a whole lot, but they were getting out there, and people are starting to realize the benefit, the clinical benefit of these. So here's an original image from 1975. It's 128 by 128 pixels. The contrast range, as you can see, is pretty minimal. It's probably a 4-bit scanner or a 2-bit scanner, if you want to call it that. And you can see sort of a generic sort of scanner here. It's very large, very small opening, and basically a head-only system. 1979, 5 years later, Toshiba actually starts marketing their own scanners in terms of the timelines. So we go very quickly from 1974 to this kind of image to 10 years later, 9 years later, a much better image, better quality, more contrast, better resolution, to 2013, and they just get better and smoother, and the image quality continues to improve. Now, I want to stop here and just give you my perspective on this, because I'm trying to talk about benefit and risk as well. And one thing we need to understand, because I'll talk about sort of the technology that's driven CT to where it is today, but I like to think of it this way. With digital receptors, which of course what CT detectors are, you have an output signal versus incident radiation. And with digital, unlike film had that classic S-shaped curve, but with digital receptors, they're pretty linear. So the more input you put into the receptor, the better signal you get out. So, your first thought is, well, this is great because all I need to do is, go up here in terms of incident radiation, I'm going to get a fantastic output signal. But as we all know, that's probably not the way we want to go. I introduce this concept of benefit to risk ratio. And the benefit to risk ratio actually is a parabola. And it looks like this, and you need to understand this. And there's a line that's going to come that's acceptable. Now this acceptable level, you'll notice there's no units anywhere here, and that's on purpose. This acceptable level depends on an individual patient. If it's a motor vehicle trauma and you need to get the patient scanned, that acceptable level can be pretty high in regards to output or radiation dose. If it's someone that's complaining, a young adult or teenager or even a child is complaining of a stomach upset, that level for scanning, that acceptable level is going to be different. So what's important is this, is we always look in radiology, and I've heard this in this meeting so far, and I've heard this in other meetings, and we all deal with this in our practices. Everyone looks at the risk of radiation, but very, very few people focus on the benefit. Even the idea of effective dose. As a physicist, I'm not sure you're aware, but in the physics community, there's a lot of controversy about the use of effective dose. On one hand, it's really good because it links different types of exposures. You can look at a chest x-ray versus a hand x-ray versus a CT, and it gives you sort of a relative risk. But it's not effective dose, it's actually effective risk. And we'd like to get away from that because we focus too much on the risk and too little on the benefit, in my opinion. So we need to look at the benefit as well. And so in this case, what we do obviously is, for whatever procedure you have, if the incident radiation is below acceptable, or if that parabola is below acceptable, then we don't go there. It's just not it's not useful. If what we want to operate on is sort of the peak benefit to risk ratio, and that would be our green zone. Now, often we're in this area here, we're above the acceptable level of risk and output signal, and so that would be considered sort of the yellow zone. And what does this all mean? What this means is, if we go this way, we're going to reduce patient dose, but we're not improving, or we may be reducing clinical benefit. And so going this way basically produces poor image quality. If we go this way and try and increase dose because we get better noise characteristics or less noise and better image quality, yes, the quality of the image may improve, but if you're not improving clinical benefit, then all you're doing is increasing patient risk without that benefit. And so this way is just unnecessary radiation dose. Okay? So we got this line of thinking? Good. So here we are, we're back here to 2013. Too many buttons. To 2013, and then of course I have to include whole body imaging as well. But we're not in 2013 anymore, we're in 2017. And now, as you know, we have unbelievable quality of images in terms of soft tissue, 3D reconstruction, we've got maximum intensity protection images, and we even do fusion now. We do fusion with CT and SPECT, or CT and PET, and so we can get functional imaging as well as anatomical detail in an amazing resolution. So how do we get there? How did we get from here to there? I mean, does that happen overnight? Not at all. Obviously, there's a lot of technology that has to occur for this to happen. The analogy I'm going to use right away is this. I mean, we go from here to here because necessity drives that innovation. And sometimes necessity could be described even as desire. And as much as we provide technology, you know, the world community in physicians and patients wants this. So you come up with the technology, and now they want this, and it never ends. And this is actually a good thing, I think. This is what spurs development. It's that necessity. So the analogy I would have is this. We don't go from this to this. Like, we don't do this overnight. This is not how the world evolves. And as you know, this could take a long time. This doesn't stop on Friday and start on Monday. It takes, in this case, 100 years of evolution. It works both ways, and nature works that way too. Evolution is not always positive. You can go from this to this in 40 years or so, right? So call that devolution. It doesn't occur overnight. If it did, we'd have a lot more divorces probably than we do now. So anyway, how do we go? We do this by slowly improving technology, performance, and the safety of the device. And I, again, draw your attention to this curve that I had shown before. Let's look at that in a bit more detail. If I call this now, I change this to clinical useful information versus patient risk. What we'd like to do is if we start, let me just go back one. If we start down here, it would be nice to be able to go and increase the information without increasing risk. That's one path that we would take. Another path that we could take would be that way. We would reduce patient risk without changing clinical information. Ideally, and what's really happening in technology is that path. We go from the original scanners in the early 70s to what we see now in 2017 and above. We're reducing patient risk, but we're also improving clinical information, which is a wonderful way to go, and that's everybody's goal. Necessity drives innovation and function, even in nature, and this is what happens. I love this slide because it looks offensive, but nobody's ever offended by it because women like the baby because the baby's cute, and men just go, mm-hmm, mm-hmm. Okay, so how do we get from there to there, which just happens to be the Aquilian primes, the Genesis 640. Now, you'll notice what's interesting is these people are about the same size, the patients are about the same size, and the scanners are about the same size. But look at the difference. You know, already, the gantry is, of course, huge. Table's much more Gucci looking and obviously does more things, more accurate. And it's about the same height, but the performance is vastly, vastly different. So what we have really is what I would call a world. It's not, you know, we say it takes a village to build a relationship, or it takes a village to raise a child. But in order to get where we've gotten with our technology, it takes a world of scientists and engineers and healthcare professionals working on a myriad of components. So I'm just going to quickly run through some of the things that make today's scanners possible. So 1971, we had the first scanner. It was single slice, single source, X-ray, single detector. It had an 80 by 80 matrix, 3 millimeter pixels. By 1975, we had the second generation scanners. Second generation scanners had multi-detectors, and it still did translate, rotate. It went from 5 minutes per slice to 2 minutes per slice, and the matrix was improved to 128 by 128. So these little letters, so it was improved clinical information and reduced patient risk. This development in 1975, a third generation was rotate only. We got rid of the translate side, so that definitely made things faster. There were 17 companies in 1975 that offered CT scanners. There's now maybe 4 or 5 worldwide. Now we have, again though, we definitely improved clinical information because we were able to do faster scanning, and we certainly reduced patient risk because the dose was slower and the patient was on the table a lot shorter time. By 1975, we had multi-detector scanners. Again, an improvement in both information and a reduction in patient risk. 1976, there was a fourth generation scanner that was introduced, which was a fixed ring detector. You'll notice there's nothing there because it was just a different innovation. It didn't really improve anything, and as you can see, there aren't any fourth generation scanners today. It was sort of an end stage product. In 1979, there was the introduction of a nutate scanner. This is where the X-ray tube was in fact outside the detector ring, and so the detector just sort of wobbled like this as the X-ray tube moved around it. Why did we have that? Well, it provided a longer source to image distance, which gave better resolution, and it reduced the ring diameter, which was an improvement in clinical information. 1982, array processors were used for faster reconstruction, so again, improved information. Multiplanar reformatting in 1985, including oblique plane reformatting. Those were really, really early days. This could take literally 10, 20, 30 minutes to do a multiplanar reformat. I remember literally going in and setting up a reformat after we had done an axial acquisition, and then going for coffee and coming back, and then finally the device was ready. Tiltable gantries, about 1987. Spiral and helical scanning, because we have better interpolation algorithms. That occurred about 1989. And then around 1990, we had fault monitoring, remote diagnostics. This was not a direct improvement in information from the clinical side, but it actually, I think, reduced the risk to the patient, because now we were able to start providing good quality control on the technology. And today what's taken for granted is pre-installation factory calibration. Back in the early 90s, the components were brought in to the location, and the on-site field service engineers spent 2 to 3 weeks setting up the scanners, setting it up, calibrating it, making sure it worked. Nowadays, you can put up a CT scanner literally in about a day or two, and that's because of these little advances. The first multi-slice scanner didn't come until 1992. That was an LSIN 2-slice scanner. Obviously improved clinical information. So remember, we're going in this path, right? We're hoping to. 1998, bolus tracking actually became something that we could put onto a computer. Well, that helped the patient, and it certainly improved clinical information. 2000 was around the time high-frequency generators replaced these old 3-phase 12-pulse monstrosities that we used to always have in a corner cabinet in a radiology room. That was important because now you could put, these were smaller devices, and that started the role to moving the generator onto the gantry, and it lessened the amount of cabling, it lessened the noise, the electronic noise. You can't ignore color displays. Flat panel color displays we take for granted, but I'm sure there's some of you in this room, remember those old 32-inch monitors that were like that deep and curved at the corners and didn't really give out good light? These are historical things now, but that's only 16 years ago. Now at my age, things have happened either only 3 months ago or 3 years ago, but this isn't that long ago, and we take these kind of things for granted, but these are also vital to improve clinical information. In-gantry electronics gave us less noise. High voltage slip ring technology didn't really get developed until about 2003, surprisingly. So you didn't have to wrap and unwrap the scanners, and so helical scanning became finally possible around then. And continuing from the beginning of '71 right up to about 2004, which was the introduction of a very high heat capacity and very high heat rate cooling tubes, we were now able to get tubes that could handle the excessive current that was required to do really fast scanning. So all of these things interacted with each other. In 2004, and right after that in 2005, we suddenly had dose modulation. So we realized that as we went through the chest cavity, we could reduce the MA, and as we went through the abdomen, we needed to increase the MA. That reduced the patient dose significantly, and people are starting to now really look at dose more than ever before. And so they did that in XY, and they did that in Z axis. Larger gantry opening started around that time too. 2007, enhanced anatomy coverage, and that really, I think, started with the Aquilion 1, the 320 slice scanner, which forced everyone to start looking at coverage, because the other vendors didn't have that slice coverage, and so they started to speed up their helical, and all of a sudden we started talking about anatomical coverage more than anything else. 2007 also, because of that, we started looking at bariatric medicine and large weight-bearing couches and very accurate couches as well. You have to appreciate these scanners are now they're doing rotations in 4 rotations a second. They're taking literally tens of millions of data points from all the different detectors. There's 1,000 detectors that are rotating 4 times a second, and each detector is being chopped or accessed or read a few thousand times a second. So there's an enormous amount of data, and this is why when we have now even faster computers, we can start doing things like iterative dose reduction, because we can start working on that raw data, which is in the millions or the tens of millions. So 2008, ultra-fast rotation speeds. 2009, dynamic collimation because of the helical nature, so that's definitely lowering patient dose, so reducing patient risk. And then we start in 2009, iterative dose reduction. So now you operate on raw pre-convoluted data, and then you got model-based reconstruction about 3 years later, and that's just still being rolled out today, but definitely a reduction in risk. And again, from the inception of CT to now, maybe 2010, there's still going to be some changes, but we're going through faster detectors, higher quantum detection efficiency detectors. Detectors nowadays are detecting 98 to 99% of the photons that hit them, so they're pretty good, and they're really fast. So everything kind of blends in together. Surface rendering, slowly the computers got better, and the post-processing improved to the point now, the original scanner was 3 by 3 by 8 millimeters. That was your voxel. Now we have 0.5 cubic voxels. That's a 600 times reduction in sampling volume, 600 times. 2018 and beyond, where are we going? What's the future? We've talked about that. Some of the speakers have talked about that already. Iterative reconstruction, that's going to get better. That's evolving. Multiple energy scanning, we've heard about dual energy scanning. There'll be talks on dual energy scanning again, but we may not stop at just 2 energies. There's certainly some work towards lower KVP scanning now because of the detector technology. That could reduce patient dose. It'll give you better contrast. There's photon counting just around the corner. That's going to give you tissue characterization capabilities. Individualized scanning techniques. People are talking about beam shaping dynamically as you rotate around the patient. You might add in beams that dynamically shape the output beam. There's dynamic X-ray beam modulation. And then it looks like some people are looking at targeted organ imaging. So, and again, there was a talk yesterday about sort of mentioning that, where if you're looking at the heart, you make sure the heart gets the amount of photons it needs to give you a good image, but everything else gets less radiation. So there's all sorts of novel new approaches, and we're going to get lower and lower and lower in dose, and thereby reduce patient risk. And what's going to be the future? Where will it end? Well, it might be wind up something like this. Because that certainly happens. You're certainly getting a lot of interactions and mergers and things. Toshiba and Canon are merging, so hopefully it won't go this way, but you never know. Okay, how are we doing for time? Are we good? I've only got a few more slides left. So if you put this all together and you look at from 1970 to now, if you look at rotation speeds, and what's amazing here is this is a logarithmic scale on the vertical axis. So this is even more dramatic than it looks. If it was an exponential decay, which is really fast, that would be a straight line. Well, this is even more than that. Our scanning speeds have gone from literally 300 seconds for that first head scanner to we're now scanning 0.2 seconds is the fastest scanner that's out there. And there was in 1989, there was an Imatron scanner that was doing 100 millisecond slices. It was a unique device that physicists liked, but it didn't have much clinical application. So that's our rotation speeds. With these fast rotation speeds and these large coverage detectors, look at the change in coverage. So this is the amount of patient you can cover in 2 seconds. It went from 1975, which was hardly anything, like literally 8 millimeters in 5 minutes, to now, because of the speed of the tables and the speed of the rotation of the gantries and the coverage of the detectors, you can cover essentially a meter of patient in 2 seconds if you wanted to. It's just remarkable. I mean, the CT scan is the shortest component of a patient's experience in visiting a CT department. They have to go get consent, they have to get dressed, then they're in and out of the table like in no time at all, and that's because of the technology. You'll see this everywhere. This is only one up going to 2006. Again, I actually did take this from the internet, surprise. But this is the increase in CPU performance. And again, this is a logarithmic scale. So we've gone from the old VAX in 1972 right up to 2006, it was 10,000 times faster in terms of processing speed. And that's 10 years ago. So it's, as I said, there was a figure that was given of 47,000 times faster. And that hasn't changed. That's not going to change. That just keeps going. And that allows us to do things like this iterative reconstruction. The original published dosimetry data from the EMI scanner brochure in 1972 or 74 was that the skin entrance dose was about 1.5 Roentgens mean and 2.26 Roentgens max. So in today's conversion, it's 14 millisieverts and 21 millisieverts. We've done a lot to reduce that dose, and that's a good thing. Perhaps this is a good thing as well. I think it is too, but look at the increase in the amount of scanning that we do as a consequence. And why do we do that? We do that because, again, there's useful clinical information and the risk to the patient isn't very great. So that benefit risk drives the fact that we use CT more than ever. And us people as radiologists or people that work in radiology, we're not the ones that are ordering the scans. We are demand driven. And I don't know how many times I've heard people having to explain that to the financial officers of a hospital or things. It's not us that are causing the exams. It's the attendant medical disciplines that want to use our services. And why? Because we produce such good benefit to risk. And that's what drives this increase. The number of CT scans performed annually in the United States, that went up to 2005. In 2015, there were 80 million. So this graph is still going up. It's not changing, and we have to address these issues. We need to reduce the dose. Well, guess what? I lifted this right off the Toshiba brochure, so this was great, off the website. And the dose is going down. It's going down remarkably well because of all of these different technologies that we've mentioned. So looking at these numbers, and again, the previous author or the presenter said this as well, you know, these are the effective doses. Now, I'm not a big fan of effective doses, but they do give you some relative risk comparison. And you'll notice, you know, a chest CT or head CT compared to a chest radiograph. Well, I was just talking to Dr. Paul, who will be talking shortly this morning after me. You know, low-dose chest now CT is of the order of your chest radiographs. It's around that same value. So we're there. And the advantage of cross-sectional imaging opposed to planar imaging is evident to anyone. So I'm ending. This is my second last slide. If you're interested, this is a recipe for making your own cathode ray tube. This is a la Roentgen. This is exactly what he used, so I'm happy to give this to you afterwards. The only thing I draw your attention to is try to resist experimenting on your own hands. Thank you.